from an exam perspective, you would like to know what all you should be knowing in terms of ventilator graphics. So this is, I've made it simple. I've not brought in all the more complicated APRV and all that. I've not included in this because you're not expected to know that at this point. You know, when you look at it in a graphic, we can always discuss that later on when you want to know more about details. But this itself was some 75, say 80 slides. So I didn't want to make it on a Friday afternoon that the girls in the class start snoozing around. I've seen that with Nehadi. Right? Okay. So you need to understand in the basics of ventilator, there are the graphics, there are what is called as scalars, and there is what are called as loops. Two things, when we talk about graphics, there are two things that we speak about. Right? And we talk about scalars and what are loops. So you classify graphics into two categories, scalars and loops. Now we look at scalars first. In the scalars, there are three categories: flow time, pressure time, and volume time. Okay? So if you look at the scalars, this is what a volume time graphic looks like. Okay? You have on the y-axis volume, on the x-axis, in all the three categories will be time. Remember, in the three scalars, the x-axis will always be in time in seconds, and your y-axis varies based on whether it's volume, whether it's flow, or whether it's pressure. So your scalars are, x-axis will always be time, and y-axis will be pressure, volume, flow. Okay, this forms the basis for scalars. Okay. Then there are loops. Okay, loops are again two types. Here there is no time element in the loop. There is pressure volume loop and there is the flow volume. Okay, time is not a consideration in the loops. So broadly, when you see a ventilator, you will look at whether you have scalars or you have the loops. And as I said, the scalars are something that you would look at. So let's look at the first component, which is the loops. Okay, in the loops you have the pressure in the x-axis and the volume in the y-axis, and you can look at it. There is inspiration which starts like that, and that's followed by expiration. Okay, and that corresponds to the peak inspiratory pressure. This is the flow, and we will address each loop. This is just a broad introduction of what loops look like. The pressure volume loop will show you the inspiration, and it will give you the expiration, and this will correspond, the peak inspiratory pressure will correspond to the tidal volume at that point. Okay? And when we come to the flow volume loop, you have the flow on the y-axis and you have the volume on the x-axis. And you start with the functional residual capacity and you start inspiration. When you reach to the baseline, that's the tidal volume at the end of inspiration. So this reflects the tidal volume here, and this is the part of the expiration. Now if you look at the expiration, there will be, in the inspiration there will be a peak inspiratory flow. So this area corresponds to the peak inspiratory flow, and this area corresponds to the peak expiratory flow. Alright? Okay? So this forms the flow volume loop. You have a pressure volume loop, you have a flow volume loop. Okay? So these are the 5 basic waveforms that you need to understand. The 3 types of scalars and 2 types of loops. Okay? All mechanical ventilated patients, you would be addressing these patterns in your graphics. Okay? So now we look at the basis of the flow volume, flow to time scale. Okay, so we will address this. So what do you look for in a spontaneous breath? Okay, this is a spontaneous breath. If you take the flow versus time and somebody is breathing spontaneously, you get a waveform which is a sine waveform, and you get an expiration. Okay, so this is the inspiration and this is the expiration. So this is what a flow time scalar will look on spontaneous breathing. All right. Then you come to a mechanical breath. That was on spontaneous breathing. When somebody is breathing spontaneous, it's very unlikely in a ventilator that without any support you would not breathe this thing. But if you connect the ventilator and without having any pressure support and allow manual breaths to take place, you will get a sine waveform and you get an expiratory waveform. So that's the scalar pattern seen in a spontaneous breath. Whereas in a mechanical breath, you will see in the flow versus time scalar, you will see a square inspiration followed by an expiration. This is a typical mechanical breath with a flow versus time scalar. Okay? Okay. Now if you look at the breathing pattern, the flow patterns can be different. You can have you see a square form, there's a decelerating form, or what is called as a descending ramp. This is called as a descending ramp, or it's a decelerating flow. This is an accelerating flow, and this is a sine form of flow. Okay, so if you're using a time cycle ventilator, there's a T1, and the T1 remains constant, and the flow which you get will vary according to the time setting that you have done. So effectively, there is also what we need to understand is that each of them represents a different type of flow pattern and it corresponds to a particular modality of ventilation. Am I clear here in this terms of this thing? You will also observe that in each flow pattern, the illustrated on this this form of scalar, you will see that the maximum flow is always in the initial parts. Okay, so if you look at the maximum flow, it's always in the initial part here. The highest flow is here, except in a time cycle where the flow may vary according to the time you have kept. If you have kept a shorter time, the flow will be faster. If you keep a longer time in the time cycle ventilator, the flow is slower. So that is like in the servo ventilators, it is time cycle. And the shorter the time you keep, the flow gets faster. So the flow is determined by the time that you keep. So ventilator manufacturers alter this so that each of these ventilator manufacturers give you a different form of. Is there any doubts here? If you have any doubts now, because you can stop me at any time and ask any question at this point. Okay. So these are the 4 different types of flow patterns that you can see. All right. Okay. So if you look at we'll now look at what is called as the inspiratory flow pattern. Okay. This is what we. It's taking too long to. I've created the graphics, but it's taking too long. Solution. हाँ हो गया मिल रहा हाँ ठीक है और कल वो सब ये हो जाएगा ना ट्रांसफर वगैरह हाँ ठीक है ओके ओके सो हाँ ठीक है ट्यूसडे को हाँ जाएंगे ठीक है ठीक है ठीक है ठीक है ठीक है ठीक है let's go back to this graphic. Okay, so when you look at a flow pattern, when you look at each waveform, you will look at there is an inspiratory pattern, there is an expiratory pattern, which we already addressed. Then when you look at it, this is where the inspiratory valve opens. The expiratory valve closes and inspiratory valve opens, and that's where the initiation of inspiration takes place. You come to this point, this is the peak infiltratory flow rate, and this is the beginning. This is the full inspiration which takes place in this particular phase, and this is the beginning of the expiration valve closure. Then you will find that expiration is a passive process, inspiratory is an active process. So you realize that when the expiration valve closes and the inspiration valve opens, this is the initiation of, and based on the flow, you will get a particular volume which will be delivered at that point. So if the particular whatever volume you set, or if you kept it at a pressure control, when it reaches a particular pressure, it will reach that particular level. But this is, we are looking at a inspiratory flow in a person who's got a volume control ventilation, whereby where you open the inspiratory valve, the inspiration takes place, expiratory valve closes, the expiration is initiated. The expirative process is much slower, as you can see, and this, the whole thing is the total cycle time, and this is the expiratory time, which is called as the TE, and this is the inspiratory time, which is called as PI. Okay, this is the classical flow thing. And if you look at this, there is, in this particular pattern, you will realize that there is, the inspiration is positive and the expiration is negative. In this scalar, this is the only scalar where you will find that the inspirative is positive and the expirative is negative. Okay, so in the flow versus time, you will find inspirative positive, expirative negative. All right, any questions here? All right. Then we come to the components of the expiratory flow pattern. Okay, this is again very similar that you can see here. What you had initially, inspiration and expiration, the time taken. Okay, that's where the expiratory valve closes, and there is, you'll suddenly see that the flow stops here. It comes to baseline, and then there is a movement when the this is the peak expiratory flow. When the expiratory valve opens here, the inspiratory stops, the inspiratory valve also closes, right? So you have a peak flow in this particular time. This is the entire duration of the expiration here, and this corresponds to the peak expiratory flow rate. Alright? And you may have this, see, your expiration takes up till there, but you may have an additional amount, and this keeps varying. Okay? If it falls short, and we will show you in various graphics later on what happens if it falls short, what will you be able to diagnose if there are various short levels in this particular case. So most important in this particular situation is that you need to notice that the flow rapidly changes direction from a positive to negative when the inspiratory valve closes and the expiratory valve opens. You will see a sudden, it's a straight linear pattern here, showing you that this is when expiration takes place. Okay, so now based on the flow time pattern, is there some common abnormalities you can recognize looking at the waveform? So I thought we look at each individual rather than address it as air leaks or airway resistance in all the 5 patterns, then it gets confusing. So we look at each individual scalar and then try and identify what we can pick up in each scalar. Okay? So when you have, there may be some degree of asymmetry, or when you have inadequate airflow. Okay? Now if you look at this, so now look at the flow time scalar here. Okay, So this is an active inspiration which takes place. This is the normal pattern, the white one. The brown one, why is it very colored? Okay, it doesn't matter. Okay, so just look what happens here. Okay, you saw the previous one. This is what a normal pattern will look like, that square. Okay, the abnormal is the patient effort here. So what you see here, can you see this, the red color? It's not straight here. This tells you that the patient is making an effort. Okay, why is it doing this? I don't know. It's automatically doing it. I think I must have made something wrong in the animation. So what you can see here is that during inspiration there is a patient effort. That effort is in fact telling you that this patient is making an effort during inspiration. This is suggestive that there is asynchrony. When you see a corrugated pattern in the inspiratory thing, it tells you it's a corrugated. It's a asynchrony in the flow time scala. Okay. Now let's look at obstruction versus active expiration. Okay. Now if you look at this, this will tell you the white one is the normal flow pattern. So if there is obstruction, you will find that the expiration limb prolongs longer. So if you look at this, this is a good curve here. You will find that this is flattened out and it takes longer to reach, and you will find this time really short. That's why I told you sometimes you might not be able to recognize this. If you had a previous thing where you can look at, you will be able to identify that this is the pattern that you will see. Of course, there are clinical telltale signs that patient has got obstruction, and you will see this pattern here. That you will see what happens here. The peak expiratory flow is below, and the time taken for patients to breathe out is this thing. Now, if you are doing an active expiration, that means somebody is actively expiration, blowing against this thing, you will find that this takes a shorter duration of time. So to differentiate between obstruction and active expiration, this is the normal time, this takes shorter time. The peak expiratory flow is bigger, longer, whereas in obstruction the peak expiratory flow is shorter and the peak expiratory flow extends to a longer period of time. So looking at this, you are able to say whether it's an obstructive disease or whether you are doing an active expiration. Alright? Okay. Now, if you have the same pattern, patient, and you then treat with bronchodilator, okay? See what happens in the bronchodilator, okay? So this is before, you have the longish, you have a short peak expiratory flow, and this. So a patient who has got bronchospasm, you treat it with bronchodilator, and this is what you will see. The effect of a bronchodilator, if it is effective, you will find that the peak expiratory flow actually increases and the duration shortens. So telling you that your airway obstruction has been eradicated. Okay? So if you follow patterns of patients who have got bronchospasm, who have got a shorter peak expiratory flow and a longer time of peak expiration, expiratory time, you will realize that after bronchodilator, you will see a conscious change in the flow time scalar in this group of patients. Okay? Alright. Then we look at, which is not very uncommon, air trapping or autopsy. So now look at the normal patient. Okay? The dotted line tells you that it always comes back to normal. So before the next inspiration starts, it touches normal. You may have zero flow at this point of time. In conventional patients, you might not, it's not uncommon to see inspiration followed by expiration by a relatively zero flow at this time, and then inspiration starts. But when the inspiration starts below the baseline, this is highly suggested that there is atrophy. Okay, so by just looking at your pattern, and if you notice that the inspiration starts below the baseline, it is telling you that this patient has got Dr P. Okay? So those are some subtle things that you can pick up in a flow time scalar. Okay? Now we move to the next scalar, which is the volume and time scalar. Now if you look at the volume and time scalar, this is not something which you will see three patterns in graphics. Okay? So this is what a conventional volume time scalar looks like. You look at the pattern here. By looking at the inspiratory limb and looking at the expiratory limb, sometimes you are able to tell. But this is what normally there is a slight convex upwards and a slight concave downwards. This is a normal pattern in a volume versus time scalar. Alright? Some recognition of common abnormalities. This is not difficult. I mean, this is what we all see. This is the typical this thing, and this corresponds, the peak corresponds to the tidal volume here. Okay? And this, when you draw midline here, that's the T1, that's the time taken for inspiration. Alright? So, what are the recognition of common things that you can identify in a volume time scalar? Okay? In a volume time scalar, you would see, like in the previous one, this comes back to baseline, and there is a zero flow before the next inspiration starts. So if you look at this scalar here, if it doesn't come back to baseline, it's highly suggestive that there is an air leak in the system. So in a volume time scalar, when you see that the expiratory limb does not touch baseline and it stops short there before the next ventilation starts, it's highly suggestive that there's air leak in the system. Yeah, I'm in a class. I'm in a classroom. Can I call you later? Yeah. Okay. Any questions up till now? Is it? Am I sounding clear, or am I managing confusion? No, it's not very. I try to make it as simple as possible. Okay. So the volume of the leak will determine the degree of. If the leak is high, you might find the values going much higher up here. So just looking at this thing, you can determine the degree of leak which can take place. Okay. So this, once you recognize this, then you need to identify where the leak is and try and fix that. Okay. So the expiratory tracing is generally smooth, and but it falls short. Okay. Now, if somebody is actively exhaling on a ventilator, okay, by just looking at the scalar pattern, you will be able to see that this person actually crosses beyond the baseline to negative. As I said, conventionally, you only see negative patterns in 2 or 3 conditions. One, of course, normally you will see the expression negative. But when it comes down like this in a volume time scalar, that means this patient is actively exhaling. So again, trying to tell you there is some dysynchrony in the patient. So when somebody actively tries to inhale and exhale, like in the previous, in the flow time, you will see a corrugated inspiratory limb. You see this all points towards asynchrony, and you need to identify why they are doing that. And there are various medical conditions to that. We are not here to discuss medical conditions of patients to identify it. That itself will take a long thing, a differential diagnosis. But these are telltale times to say that there is a leak in the volume time scalar. Okay? So we have done 2 scalars up till now. We come to the 3rd scalar, which is the pressure and time scalar. Okay? So let's look at y-axis pressure, and we look at time versus time. Okay. Now here We saw in the flow type, the spontaneous breath was sign followed by a negative pattern. In the volume, in the pressure was to time scalar, you will realize that the inspiratory is a negative effort and expiration is positive. Okay, so this is opposite of in a spontaneously breathing person. If they spontaneously breathe on this thing, you will find inspiration is a negative phenomenon. Okay, followed by a sign expiration pattern in a spontaneously breathing patient. Whereas in mechanically breathing patients, it somewhat resembles the previous scalar. As you can see, you have an inspiratory pattern and an expiratory pattern, and this determines the peak airway pressure of the person. Okay, so in a mechanical breath, when you look at pressure versus time scalar, you will see that this is the expiration. What does this represent? P. So conventionally, if you don't have peak, you start from the baseline here. But when you have apply peak to a person, if you look at the pressure to time scalar, it starts at the, if your peak is 5, it will start from 5. If your peak is 10, it will start from 10. This is the 0 line. So this level reflects the peak. So by looking at your pressure to time scalar, you can determine how much peak has been applied to this particular patient by just looking at the graphics. Okay, so again, you have a concave, convex pattern here and a concave here. This corresponds, the peak of this thing corresponds to the peak inspiratory pressure, and that's when expiration starts. And this is the inspiratory time and the expiratory time by looking at it. And of course, by looking at these time intervals, you are able to determine certain parameters in these patients. Okay. Now we come to, in a pressure time scale, we look at how an assist controlled breath will look like and how a controlled breath will look like. Now, in the assist controlled breath, you will find when the patient triggers the ventilator, you will find this pattern here. So in your pressure time scalar, if by just looking at this, if you say assist control, we use assist control mode all the time. But when the patient doesn't assist, it gives you the delivered tidal volume, the delivered breath that you have set it at. So if it is at 12 per minute, so every 5 seconds it will deliver a breath. But in the interim period, if the patient triggers the breath, it will deliver the same amount of breath that is there. So by just looking at the pressure time scalar, you are able to determine which is a patient triggered breath and which is a machine delivered breath. So by looking at this, you are able to say, well, every time that the patient, each breath which is triggered is a patient. Okay? Not very difficult. Okay? What are the components of the inflation pressure which we actually will see? Okay? When the inspiration begins, you get this pattern here, then you get a peak inspiratory pressure. And in that time, there may be no flow. Okay? When the inspiratory valve closes, there may be no flow. And then you have a plateau pressure. Okay? Followed by the expiration. This is when the expiratory valve opens. So this begins inspiratory valve closes here. Okay? Then the pressure stabilizes. The initial rise is because of the airway obstruction. Whatever the airway pressure, airway which causes these things gives you the peak inspiratory pressure. Then there is no flow, it stabilizes, the pressure comes down, and that corresponds to the alveolar pressure or the plateau pressure. So when you look at this pattern here, you will see a peak inspiratory pressure, and you will see the plateau pressure. And when that expiratory valve opens, the expiration begins.
So is the trans airway pressure same as P resistor?
No. Trans airway pressure is related to the airway pressure. It is related to the airway pressure. So it will, if the airway pressure is very high, it will change. I will show you in the subsequent thing what will happen. Okay. So this is the basically the airway pressure. it determines the degree of the airway pressure. Alright? So, am I clear here as to what this looks like? Anybody have any doubts? Okay? So, the trans airway pressure is actually the peak inspiratory pressure minus the plateau pressure. That's the trans airway pressure. Alright? Okay? So, plateau pressure corresponds to the alveolar pressure. Basically, it tells you the compliance of the lungs. Okay? Right?
Trans airway is the atmosphere and the alveolar pressure difference.
Which one?
Trans airway.
Trans airway pressure is the peak inspiratory pressure
Yes.
and the plateau pressure. So it basically is a determinant of what is the degree of in your passage in your airway.
So
in your
resistance
bronchi.
only.
Resistance. It really
It
corresponds
corresponds
to
to resistance. That
Yeah.
is that's
Okay. All right. Okay. So just to give you another view of what this really means, you can look at it in terms of airway pressure when it begins. This, as we said, determines resistance. Okay. So the more the resistance, this goes up higher up. Okay. The peak inspiratory pressure goes up. This, the plateau pressure, which is basically determined by the hold time. You need to put a hold time because there has to be no flow. To get a plateau pressure, if there is no hold, you won't get a plateau pressure. Okay? So you need to have a hold time. Usually 0.1 second or 0.2 seconds, which actually tells you this. Okay? So based on your airway pressure, this will keep rising up, your peak inspiratory pressure. And based on your compliance of the lung, your distending alveolar pressure tends to go up, your plateau pressure will go up. So this graphic kind of tells you which pressures are increased in which medical conditions. Okay? Now, coming to what are the abnormalities that you can recognize in pressure versus time scale. Alright? So let's look at peak inspiratory pressure versus plateau pressure. Okay? So what is this? This is hello. Yeah. Yeah. Okay. Yeah. How about was it flood water or puddle? That doesn't correspond to requiring doxycycline. Just take a conventional antibiotic and gram-positive augmentin or something. You can take doxy also. It also counts gram-positive. Yeah. 100 mg for 3 days. Okay, now did you understand what's happened over here? It's pretty self-explanatory. Okay, alright. So this is normal. When you have an airway obstruction, high airway pressure, this is the pattern you will see in your pressure to time scale. And whereas you can also get a similar if you increase your flow. See, suppose what does flow do? Flow, if you have a high flow, say 50 liters, 60 liters, you will deliver the same tidal volume at a shorter time. So your airway pressures will tend to go up. This doesn't mean that there will be that this is airway obstruction. It's simply because you have increased your flow. You wanted to get X amount of, this is a volume control mode, you wanted to get 500 ml of volume in say 2 seconds. You send it in 1 second. What's going to happen? This is going to go in that direction instead of going in that direction. So it's basically your pressures go up fast, and that and there is no alveolar problem. So you will get a feeling that this is high airway obstruction, but this may effectively be due to because of increased flow with a normal airway. So this and this may be similar, but what you can see is, look at this. Here the plateau time is shorter. Here, because the inspiratory time, look at the curve here. This curve is more steep and it comes down like this, but look at the time taken. That means there is really not much of, this is a longish plateau time, suggesting that you have probably increased your flow. You need to solve. Okay. All right. And this, of course, tells you that this is typical of ARDS, compliance, low compliance, and this pattern really shows you what the situation is. Okay? And now we come to increased airway resistance. Okay? Now, this is just to, because I gave you one thing in a short time, all three components in this thing. We'll just look at each individual pattern of the pressure versus scalar. Now, if you actually take a shot of this, and if you look at the line running across to the beginning of the peak inspiratory pressure, you will realize that as the airway resistance decreases, this becomes a little bit more flatter around. Okay, suggesting that these patients have got a increased airway pressure. Now, if you looking at the flow pattern here also, this is what the normal flow pattern is, and you will see here that the flow here is so rapid. So this is just breaking up what each individual did in terms of telling you that this is a person with a high flow rate, this is the person with a high resistance offer. Okay? Now, in terms of, this is when the flow is very high, this is the same thing as I said, but if you look at the pattern here, you will realize that when you cut across in a high flow, this thing with a peak inspiratory pattern, you will find what is called as a dynamic this thing. So if you overlap both the scalars, you will realize that if you coincide it, and you will find that the time between the plateau pressure of the high flow pattern and the plateau pressure of a normal pattern, you get what is called as, this time is called as a dynamic inspiratory time. And this inspiratory time tends to be decreased in a high flow pattern. Okay? If you look at this, in a high flow, in a normal person, this is the normal phase. So if you look at the high flow person, there is a decrease in the inspiratory time, which tells you that the inspiration is faster. So you can actually measure it if you choose to measure it, determine whether it is flow related problem or a peak airway related problem. Okay. When it comes to low compliance, you again overlap this, and you can see the difference. This is the normal plateau pressure, this is the compliance. By measuring this, you can actually tell what is the degree of compliance which is there, and that most of your ventilators will actually measure these parameters and tell you. That's what they measure. The compliance is measured based on the plateau with the normal and plateau with the this thing for that particular patient. Okay. So now if you have a flow pattern and you want to look at the flow pattern to see if you're not giving adequate flow to a particular patient. So basically ventilator settings can be determined to change by looking at your flow pattern. Look at this flow pattern here. So this patient seems to be alright in terms of the curve. Look at the curve here. And look at the curve here. This is straight. Okay? So when you see a pressure time scalar where you don't have you have a straightened inspiratory limb of the pressure time scalar, it tells you that this patient has got inadequate flow. So you may need to increase the flow, and it's not uncommon when you see the Puritan penetrator ventilator which we have, and you try it on a patient, keep the flow at 30. Okay, he might need 40, 50.
So often we used to get a concavity.
You can get a concavity. When it is more, if it is terrible, I think the patient's efforts are much more. But subtle changes. The idea is you need to pick up subtle changes. That this line is straight. It should never be straight. It should have a convex pattern. Okay? So you need to understand that. Alright? So now you can look at this. I've just made you a flow pattern. This is adequate flow. If the flow is set too low, you can get a concave pattern. You can get a irregular pattern. Okay? With some convexity. And again, as you said, there's a concavity in these patients. So by looking at your inspiratory limb, you can determine whether you are giving adequate flow to your patient or not. So you adjust your ventilator to increase your flow of your patient. Okay? Try this on the Puritan Bennett ventilator. You will look at the waveform and you will recognize when you reduce the flow, you will see this happen again. So it's best way to look at it. Okay? So that's about the scale out. Now we come to loops. Okay? So let's look at the basic of the pressure volume. Okay? So pressure volume loop, what is the type of breath that you can actually see in this particular group of patients? Okay? That's a controlled breath. Inspiration, expiration. If you take an assisted breath, you will see that it has a pattern like this. It goes like that, comes like that, and it crosses over. Just keep this in mind because it also contributes to determining the work of breathing. Okay? So this is just to show you. I wish I had slowed down some of these ones which needed to be shown. Okay? So this is a controlled breath, as you can see, starts from the baseline, goes up, and expiration. This is an assisted breath. It goes like that, comes like that, and goes like that. And this is a spontaneous breath. In somebody who is taking a spontaneous breath. Okay? So the pressure volume loop will look different in each of these conditions. Okay? Okay. So let's look at functional residual capacity and look at the PV loop. Okay? So in a normal compliant, you will see that this is how the pattern will look like. This is, if you take the flow volume loop here, you will see that this is where the functional this is where there is the functional residual capacity of the lung, and you will see that this is the flow pattern that you can see. And if you see the compliance of a normal lung with the total lung capacity, this is how the pattern of the flow PV loop will look like. Okay? The pressure volume will look like in this particular pattern. Okay? So that's the inspiratory limb, that's the expiratory limb. It comes down to baseline 0. And if you draw a line here, now this is the peak inspiratory pressure, okay? And this is the amount of tidal volume that you have given to this patient by looking at the loop. You are able to say what is the tidal volume of the patient, what is the peak inspiratory pressure by looking at this, okay? Now, if you put P on a PV loop, what happens? Because the airway pressure is plotted here, instead of starting at the functional residual capacity, it moves towards the right. So this determines the degree of peak, and this is how when your peak inspiratory pressure will move slightly to the right based on the peak pressure. So this is the typical pattern of PEEP applied to the PV. Okay? Now, in the good old days, there was a thought that if you use inflection points, it's where you probably could determine where is the. So there used to be something, you see, where it turns, this is supposed to be the lower inflection point. If you look at the curve, this is the inspiratory limb. The point where it curves is supposed to be the lower inflection point. Then it goes up, and then where it curves up there, that's supposed to be the upper inflection point. Now, it was a thought process, and a lot of studies have been done on this, that the PEEP should be kept above the lower inflection point. And you should not let the upper inflection point go up, because that determines degree of over distension. So, by looking at your upper inflection point and lower inflection point, people would keep just slightly above the lower inflection point and would not allow the tidal volume to see that the upper inflection point moves up. So based on the upper inflection point, they would decide how much tidal volume to use. But most of the studies have not proven that that's really a great method of doing it. But a school of thought, especially European investigators, felt that if you keep the PEEP at the lower inflection point, that was probably the right way to go to keep the lung expanded and prevent de-recruitment of the lung and prevent over distension by seeing that the upper inflection point was not too high. We like to keep it a little lower. So those were the things that they kept at. So based on the upper inflection point, the tidal volume would have been adjusted. That's what used to be done. Okay? Now, if you look at the PV curve, you will see 2 or 3 things. Okay? You will look at this. This is what is the This is the inspiratory component. This is the expiratory component. Now we know that inspiratory is an active process, and expiration is a passive process. Now, what does this tell you? This tells you that based on the resistive work, that means if there is a lot of resistance in this thing, your pattern will change here. This will become more round, and I'll show you in a later slide how this changes. And based on your elasticity, you would look at how this curve would look at. Okay? And based on that, you can actually look at what is the work of breathing in these patients by looking at the curves of both the inspiratory. And then when you look at PV curves in terms of volume control ventilation, you will realize that when there is an decreased compliance, you will find that this is normal. This is, say, in increased compliance, the yellow one, and the pink one is where the compliance is decreased. Now, what do you see in this? You see in the one with the decreased compliance looking more flatter like this. See, and you can see a peak. You can see this moving more towards the peak inspiratory levels, moving more towards the right. If this is the normal level here, if the patient's compliance decreases, the peak inspiratory level goes down, and the curve tends to go downwards. Whereas if the compliance is increased, say like in emphysema, the curve tends to stand up. So by looking at the curve pattern, you can look at what the compliance of the patient is. So simply by looking at that. Okay? So again in pressure, this was in volume control mode. So this is how it would look in a volume control mode. In a pressure controlled setup, this is when you do the pressure targeted ventilation, you will realize that it is even more, when you keep a preset this thing, it's even more flatter as the tidal volume tends to decrease in a pressure control mode. So you will find that in a pressure targeted sleep, you will find it more flatter. Okay? So in decreased compliance, you will see that this is what happens. This is what a normal patient looks like. In a decreased compliance, this is what it looks like. So there is a clear movement of the PV curve to a more flatter or a more decreased angle in these people. Okay? Now what happens in increased airway resistance when you look at the PV curve? This is the normal slope that you see in this patient, and in patients with the airway resistance, you see this is what happens. That inspiration takes longer, it takes a longer curve. Okay?
The resistive work is increased. Then
Yeah.